Hi everyone, thank you for visiting my channel and thank you for listening to my presentations. Today I'll be talking about infertility in females. A lot of people are affected worldwide and I have published infertility in males, encouraging females to listen to that so that they will be able to help their male partners. Right now, I'll be encouraging male partners to listen to this so that they can help their female partners. And if you have friends that is passing through this, after educating yourself today, you can become a teacher or someone who will be able to give appropriate pieces of advice afterwards. Um, like I said, I will limit myself to causes and I may not be able to say some stuff or pronounce some words the way they're supposed to be because some children may be around while you're listening. I will have that at the back of my mind, and that will dictate how far I'm able to go in calling some organs or naming some stuff or saying some things the way they ought to have been said. So kindly forgive if you think that means conservative somehow. Okay, with that in mind, let's go. When we are talking about infertility, though I'll be talking about infertility in females, it won't be complete without listening to infertility in males. So check my channel. 38% of factors causing infertility in a couple is attributed to females. 20% will be male factors, while both will share 27%. And sometimes after doing investigation, we might find nothing, we call it idiopathic, or even sometimes both male and female are both normal. No problem, but it's just like that. We can explain why. All those will constitute about 15%. How do we define female infertility? Generally, infertility is defined as the inability to conceive after 1 year of unprotected interaction. Remember I said I might not be mentioning some stuff the way I've written them down. You just read it there. Sorry about that. Primary infertility means no pregnancy in the history of this woman. No pregnancy, never. In fact, no miscarriages, no abortions, everything is zero, no pregnancy. That is primary infertility. I hope all females will be honest with their doctors and partners so as to know who is truly having primary infertility apart from people having secondary infertility, because different situations will dictate what some patients will say sometimes. By the time some don't want their partners to know that they've ever had pregnancy, they've ever aborted, they've ever had kids, they'll present themselves as if they're having primary infertility. Okay, secondary infertility, on the other hand, means this lady was pregnant before. The number of times she had carried pregnancy is something else, but the issue is just there. Once upon a time, she was pregnant, either carried to term or preterm or abortion or miscarriages. All we're just looking for is once upon a time, this lady was pregnant. That is secondary infertility, meaning had pregnancy in the past, regardless of what happened to that pregnancy. Now, for a whole year with the spouse, no pregnancy. That is secondary infertility. Okay, female factors. You remember I said female factors will be up to 38% of all factors causing infertility, right? Now, let's break down those female factors, and that's why we are here today. In females that are infertile, the majority of the factors in that woman will be related to ovulation. So, ovulatory problem will constitute 25% of reasons why females are infertile. If you check my video by next week, there will be detailed physiological explanation about ovulation. Every stuff you need to know will be published by next week. 15% will be associated or related with endometriosis. You can check my channel for endometriosis. I have that published already. Just check my channel, you find out. So 12% will be as a result of pelvic adhesion, and 11% as a result of Tuba anomalies. I will go into details of that in a bit. 7% will be dealing with hyperprolactinemia, sending negative feedback to the hypothalamic pituitary ovarian axis. We'll go into that later on. Yeah, age-related infertility. Well, it's tagged age-related because the age at which you're going to find each of these items will differ slightly. For example, menopause. I have a separate presentation on menopause, and I wanted to check my channel for that. Menopause is, in those days, it used to say 50 and above. Nowadays, people are getting into menopause. That is complete 1 year cessation of menses, right? Some are getting to it before 50. So what we now have is 50 years plus or minus 5. So if you minus 5, that is 45. If you put 50 plus 5, that is 55. So there's a big gap, 10 years gap between 45 and 55 for menopause. So people in that age group could be dealing with menopause if they are having amenorrhea and they are infertile. Okay, fibroid. Fibroid is found in the end of third decade to beginning of the fourth decade of life. 30 to 40 years. Now, people that have fibroid, that is the time most of them will know for the first time that they have fibroid. But that doesn't mean that they cannot have fibroid beyond 40 years. They can have, if they have it at maybe let's say 35, and they are still menstruating regularly up to 45 and above, because once they get to menopause, of course, trouble with fibroid will be minimal, will be decreasing as they grow in menopausal years. Tubal diseases, yeah, it's not the case like menopause. Tubal diseases could be found in younger age group, the young adults, okay, 21 and above. Anybody could have tubal disease after 21. Even now, some before 21 can have it, 18, 19 can have it. So you could see that it is age-related, right? So what we thought we'll find in menopausal women, we're not expecting the problem of menopausal women when we could find tubal disease problem at younger age group. Adolescents, young adults could have tubal disease. Let me quickly chip in something that if you are picking signs and symptoms of menopause in someone younger than 45 or 55, younger than 45 to be specific, you are dealing with premature ovarian failure, please. I'm glad I remember that. Then when it comes to endometriosis, Endometriosis is found at the third decade and fourth decade of life. That is 25 to 35, thereabouts. Okay, that's why it is age related. And of course, decreased coital frequency is found in different people. Some may choose not to have it, but medically, people with menopausal symptoms will have vaginitis, they will have decreased secretion, so they have dry, organ down there. You understand what I'm trying to say? Because of that, they may not be enjoying interaction. So apart from the fact that it's likely that they have decreased libido, they will not even be enjoying it, so they are not that excited. So at that age, at menopausal age, there was likelihood of decreased coital frequency. But some, maybe because they have dyspareunia or any other problem that could occur in any of the age groups, so will probably lead to decreased coital frequency. Now, polycystic ovarian syndrome, and this will form a separate presentation later on. Here, like the name, there are a lot of cysts in the ovary. Ultrasound will pick that, CT scan will pick that. They could be obese, they have hirsutism, they have anovular menses, okay, irregular menses. They have irregular menses that is pointing to anovular menses. So in them, they have, some of them have diabetes mellitus, and we give some of them metformin, but pioglitazone will help with infertility and still handle the glucose problem. But the side effects of pioglitazone is horrible compared to metformin because it has fluid retention problem, myocardial ischemia, and so on. Chemotherapy to those who have cancer and they are looking for pregnancy is a serious issue because the chemo will indiscriminately destroy growing cells. And by the time we get into details of ovulation, you understand that ovary will have what is called the effect of follicle stimulating hormone that will stimulate the follicles. And later on, the luteinizing hormone will come in, having luteinizing hormone surge, and then releasing the egg to the oocyte. That is a process that is involving, growing cells. So chemotherapy will kill that. Combine oral contraceptives, where we'll go through the ovulatory system or pathway or mechanism, we'll understand that high level of estrogen and progesterone will send negative feedback to hypothalamic pituitary ovarian axis, and that will cause decreased production of follicle stimulating hormone and luteinizing hormone. And when we don't have FSH and LH, we are not going to see the egg that will be released from the ovary and then flow through the fallopian tube to meet the spermatozoon, and then fertilization will occur. That will be cut off. It's not going to happen. So that is why combined oral contraceptives is very effective in contraception. So because it's going to keep the concentration of estrogen to be very high. Corticosteroids will affect ovulation as well, just like in Cushing's disease. Because Cushing's disease will have high level of cortisol, they have buffalo horns, they have striae, truncal obesity, hypertension, and the like. So high level of cortisol will have negative effect. And antidepressant and then antipsychotics. The two of them, I am bringing them together because they may increase prolactin, particularly antipsychotics, and they both disrupt the process of ovulation. Anything that alters ovulation would definitely lead to infertility because that's what the woman is banking on. Not only that, they would decrease the effectiveness of fertility drugs. Like, for example, you've picked the patient, you've given what you're supposed to give after doing your test, and you prescribe your, uh, fertility medication, and the person is on antipsychotic, at the same time, the effectiveness will be decreased. Now, they can increase the rate of miscarriage and the rate of preterm birth. Men will find it difficult to impregnate their wives. That's why I said when it comes to this matter, we need to involve both. So people that are on these medications, selective serotonin reuptake inhibitors and antipsychotics, and are planning to be pregnant should have a serious conversation with their psychiatrist. Okay, premature ovarian failure. The other time I said it that menopause is cessation of menses after 1 year. Now, premature ovarian failure, if there is cessation of menses before the age of menopause, that is when we have premature ovarian failure. So it could be as a result of many things. It could be as a result of medication, surgery, disease, anything that could just end the production of follicles from the ovary. Is premature ovarian failure. And the presentation will be like a woman in menopause. Radiation, just like chemotherapy. Radiation is like chemotherapy, so it will destroy the growing cells indiscriminately. CN syndrome is known as postpartum hypopituitarism. People may not pay attention to this. When women are pregnant, then they have delivery, either through cesarean section or vaginally delivered, and later on they have postpartum hemorrhage, or not even just immediately they could they could lose massive blood. So the key here is massive blood loss, due to childbirth, and that will now affect the pituitary gland, and the pituitary gland will be hypofunctioning. That will lead to deficiency or low level of many hormones, like follicle stimulating hormone, luteinizing hormone, prolactin, growth hormone, thyroid, and adrenocorticotropic hormone. The level will all drop. And for a woman who was normal in first pregnancy or second pregnancy, then because of postpartum hemorrhage, she is finding it difficult to conceive, might be dealing with CN syndrome. Apogonadotropic apogonadism, like I have alluded to that about twice before now, that there's what you call hypothalamic pituitary ovarian axis. So gonadotropin releasing hormone from the hypothalamus, sending impulse to the pituitary to release FSH or LH, and that will work on the ovary, who will in turn be the source of the oocyte and estrogen and progesterone. Progesterone from corpus luteum to encourage the uterus to hold the pregnancy in place until term. You understand that cascade of events? So when there's problem with the hypothalamus and there's problem with the ovary, of course, there's a problem everywhere. So hypogonadotropic hypogonadism. Pituitary adenoma. Pituitary adenoma will be leading to LH and FSH deficiency. And of course, lymphocytic hypophysitis is an autoimmune condition. And I've said in some of my presentations that when you pick one autoimmune disorder, you better look for the rest. So when there is autoimmune situation affecting the hypophysis, then you are going to deal with situation where the production of FSH and LH will be impaired. Eating disorder and intense exertion. Many people don't notice this. Like typical example is a young lady having anorexia nervosa. Of course, the menses will become irregular, and that is a clue that the cascade of events from hypothalamic pituitary ovarian axis is disrupted. And when that is the case, and you are looking for pregnancy, you better run to your doctor and get everything put in place. I agree with him to help you. So, eating disorder and intense exertion can lead to infertility because it might lead to irregular menses. The same with stress, matrimonial stress or academic stress, like university undergraduates preparing for exam. They might notice that their menstrual cycle will become disrupted, and anything that will alter your menstrual cycle could alter the rate of fertility as well. Hyperprolactinemia for sending negative feedback that will be in tandem with breastfeeding or lactational amenorrhea. So they are the same, okay? So the doctors will know that hyperprolactinemia and breastfeeding will be the same, okay? So that will send a negative feedback. And that is part of the problem with even some antipsychotics, because some antipsychotics will actually give hyperprolactinemia. When there is that situation, there'll be negative feedback to the hypothalamus, which will affect the rate at which the message will be sent to the pituitary to release FSH and LH. And when that is cut off, then the follicles are not being stimulated, no maturation of follicles. There's nothing that luteinizing hormone is going to luteinize, if at all is available. And when we don't have the oocyte, we are not going to have fertilization. And hypothyroidism. The first question about hypothyroidism is, what has even caused the hypothyroidism? Is this as a result of autoimmune disorder, Hashimoto's thyroiditis, or even hyperthyroidism? Is this as a result of Graves' disease? Because in both cases, the autoimmune situation will also affect ovulation. And in Graves' disease, there will be low sperm count and irregular menses. So, no, I don't pray to have either of these, okay? And I wish you the same. So, in a woman that is infertile, it will be wise if we are trying to come down on the cause of causes to have TSH, T3, T4 done. I know many people will just do progesterone, well, by the time we go to that level. Some will just do progesterone, do HSG, and do, FSH, LH, prolactin, and they're done. If you do all those and you can't get the cost, go back and still go. You could see many things now that we could, work on. Okay, still on ovulatory problems, chronic liver disease, chronic renal disease. Somebody will be asking, what is my business with liver and kidney, with my infertility? Oh, don't be upset. When you have high level of estrogen, the liver should metabolize that. But when there's liver cirrhosis or liver failure and estrogen is not being metabolized, like I've presented in male infertility that will lead to gynecomastia, right? In females, that will send negative feedback to the hypothalamus. So hypothalamic, pituitary, ovarian axis will be disrupted. I mean, the communication won't be the way it should be. And if I told you I'm going to have menses, it's going to be anovulatory menses, not ovulatory menses, because by the time the level of estrogen is high, where are you going to get your FSH LH? You're not going to get. And when there's no FSH, follicles are not stimulated. There's no follicle growing. When they are not growing, what is luteinizing hormone going to work upon? And where is the oocyte? Where is the egg? Fertilization with what? It's not going to occur. Now, congenital adrenal hyperplasia. There's an overlap here with polycystic ovarian syndrome, okay? And they will both present with anovulatory menses. And that's it. Anovulatory menses means anovulatory menses, but one clue that will let you know that this is anovulatory menses. Oh, somebody is whispering to me that you think everybody will understand anovulatory menses. Do you think you are talking to only doctors? Oh, I'm sorry about that. Anovulatory menses means the person is menstruating but not ovulating. Ovulating means you are releasing egg, okay? Not releasing any egg, but still, shedding the slough that's already in the uterus, and then there's bleeding. So, but it's going to be irregular. That's one clue to anovulatory menses. It's going to be irregular. It will be irregular. Ovular menses will be regular, will be fixed time. I'm going to find it. Androgen insensitivity syndrome. In this case, it's going to be from birth also that sexual development will be affected. Externally, that is phenotypically, the person will be looking like female, okay? But they will not have uterus, they will not have menses. So they will present with primary amenorrhea. Now, problems with the tube. The tube, let me just give you the background here why the tube is important. The tube is just the channel, okay? The ovary at the flanks, the uterus at the center, and the tubes are the passageways through which the egg release will roll down from the flank, and the product from the man will have to swim up to meet the egg for fertilization. So any problem with the tube will prevent fertilization. And that's it. When there's no fertilization, there's no zygote. And there's nothing to divide to become embryo and fetus later on. So pelvic inflammatory disease with secretions, severe endometriosis, surgery along the pelvic region that has led to adhesion, fusion. So the passage is occluded. And of course, related organs infection around the tubes like appendix, inflammatory bowel disease, TB affecting the pelvic region, or salpingitis. All those would cause possible adhesion with massive secretion. Even the secretion alone is enough to prevent fertilization, because by the time the egg cannot flow down through the secretion, or the spermatozoon can't flow up to meet the egg, nothing's going to happen. There will be no fertilization, okay? Hydrosalpinx. This will occur at distal tuber level, occluding it with serous or clear fluid very close to the ovary, and that will prevent fertilization. And usually, Adosarpines will be bilateral, and then we'll call it adosarpinges. It's a serious problem because fertilization won't occur. Hematosarpines, on the other hand, is when there's a ectopic pregnancy, and that will lead to blood accumulation in the fallopian tube, or it could be tubes, but I pray not. Mostly, ectopic pregnancy will be affecting one tube. There is a separate presentation on ectopic pregnancy. You can check my channel for that as well. Pyosarpines, that is, there is pus in the fallopian tube from pelvic inflammatory disease. All this will affect the tubes and even the cancer of the tube. Yeah, I'm not ruling that out as well. And also affecting the tube when there's a ectopic pregnancy and the portion with ectopic pregnancy is excised. You understand? That might be a problem. And even deliberately, tubal ligation. Now somebody just felt, I'm no longer going to be pregnant again. Doctor, please tie this up. And doctor has tied the tubes up, tubal ligation. Later on, she finds the man of her love or interest or whatever, but not honest with the man. And the two of them are visiting doctor, but she's not telling the doctor the truth that I had my tubes tied before. So doctors, please, let's really find out so that we don't just be laboring in vain. Fibroid. I mean, uterus now, fibroid will be revealed in there. Like I've said, as a separate presentation when it comes to fibroid, you can check my channel so I won't waste your time here. But let me quickly mention here, as far as infertility is concerned, if the location of the fibroid, because fibroid could be outside, that is serosa, could be pedunculated when it has stalk and attached to serosa, it could be intramural, in the thick wall of the uterus, could be submucosa, that is, the lining of the uterus, and could be cervical, at the cervical region of the uterus. Out of all those different sites that I've just mentioned in the last 2 seconds, we are concerned about the submucosa or intracavitary sites. That will be the ones that will prevent implantation. And even if implantation should occur, the continuation of the pregnancy will be very tough, with submucosa fibroid co-inhabiting the submucosal layer with placenta and the products of conception, I mean the fetus. It's going to be tough. If the fibroid is serosa and then pedunculated, even if it is intramural but it's not punching into the submucosa, just lying there in intramural, then they could grow together, giving rate degeneration, which is just going to present with serious pain, right? Okay, endometrial polyps. I've just talked about submucosa fibroids. It's not different from endometrial polyps. Polyps in the endometrium will not let implantation be smooth, and of course the retention of pregnancy will be difficult, so there could be miscarriage. Uterine syncytia, yes, when people have abortion, either therapeutic or none, and it is at the stage where dilatation and curettage must be done, because if it's not done early, then you have dilatation and curettage. By the time it's healing up, there's likelihood of uterine fusion. And not all the time that this uterine syncytia will be secondary to abortion. It could be for good reasons sometimes that coital non-dilatation has been done, maybe to make diagnosis of endometrial carcinoma, or somebody is just bleeding profusely and you are just looking for all possible causes, and then you have dilatation and coital done, or placenta retention, and then the next thing you resorted to is dilatation and curettage and suctioning of the product. So anything that could lead to curette, being used to scrape the uterine wall, the aftermath, if you don't place any device in need for it to heal without adhesion, there could be uterine adhesion. And when we have that, you know what will happen? Well, all the doctors do, but for my sisters that are not familiar with this, there won't be possibility of the oocyte from the ovary to roll down the tube and get to be fertilized by the spermatozoon. And the content from the spermatozoon won't be able to go up and be fertilized, meet the egg to be fertilized. And where is the implantation going to occur when everything is fixed? So adhesiolysis will be done. Failure of corpus luteum to produce progesterone, that is luteal phase defect. When there's fertilization, okay, then the corpus luteum, the part of the Graham follicle, or the follicles that matured and release oocyte, would develop to the corpus luteum and then be producing progesterone. Okay, woman chorionic gonadotropin will be expected to take over that role when the luteal phase passes off. Okay, and later on, placenta will take over the production of progesterone. Why? Why do we have that 3 stages in one pregnancy? Because progesterone is very, very essential to keep the product of conception intact in the uterus, okay, for nidation and prevent contraction of the uterus. So what will happen then if this level fails, or if woman chorionic gonadotropin is not producing enough, or placenta is failing in its duty? There will be low level of progesterone. And when there's low level of progesterone, then the uterine contraction could occur at any time and push out the entire content of the product of conception. So progesterone is necessary to keep the pregnancy intact until term. At term, then the level of progesterone will be dropping. And what will happen? The level of oxytocin will be rising. Oxytocin will always have positive feedback. As the level is rising, more will be rising. Then what will happen? Contraction, which we call labor. And when that is not the case, then we need to augment the labor by giving exogenous oxytocin. So at that time, progesterone is down, releasing, handing off everything. Okay, I'm gone. Uterus, you can push everything here out. That's it. People with this problem are actually assisted with exogenous progesterone. I have made a separate video on the role of progesterone and preterm birth. Please check my channel for that. Endometriosis. Most women with endometriosis are infertile. I will not waste your time on that. Check my channel. There will be secondary pelvic adhesion. Don't let me say authoritatively. There's likely of secondary pelvic adhesion in people with endometriosis. Now, endometrioma destroys ovaries. By the time the lining of the uterus, endometrial tissue flows to the ovary and overcome ovary and sit down there and start growing endometrioma. They will destroy the ovary, destroy the function. So even if you have follicle stimulating hormone, what is it going to work upon when there are no follicles that could mature and release the oocyte? Then high cytokines and growth factors will impair ovulation, fertilization, and of course, implantation. So if you escape ovulation, if you are able to ovulate, how about fertilization? If you risk it and you make your way through and you have fertilization, how about implantation? So people with endometriosis are dealing with a lot. The cervix. Cervical stenosis could occur secondary to surgery, and that will lead to two possible things. It's either preventing fertilization or, in addition to that, decrease mucus that can improve sperm transport, or both. Autoimmune diseases. I've alluded to this many minutes back. This will affect fertilization and implantation because of inflammation of the ovaries, that is uveitis. Premature ovarian failure will occur when the ovary is destroyed. Autoantibodies could occur and be targeting many endocrine organs, like including the pituitary gland can be targeted, and infertility is associated with systemic local erythematosus, myasthenia gravis, celiac disease, and so on. You remember I said this when I was talking about Hashimoto's thyroiditis and Graves' disease of hyperthyroidism. So people who have autoimmune diseases and they are infertile should know that's not strange. It is the same thing that has happened to the affected organ on account of which they presented that has happened along hypothalamic pituitary ovarian axis. Genetic. Okay, Turner syndrome, 45XO, Klinefelter syndrome, giant, 47XXY in men, Hammer syndrome, Fragile X syndrome. Each of these is different presentation already. I can't promise when I would work on them, but just know that people with this diagnosis of these chromosomal anomalies will have infertility. Lifestyle. I've talked about excessive exertion and eating disorder, that is anorexia nervosa, and the rest the other time. Increased weight. Someone is asking me, what's the business with my weight and infertility? That has nothing to do. It has a lot to do. That might be the only problem you have. Because with your increased weight comes increased level of estrogen. And that will send a negative feedback to the hypothalamus. And there won't be the release of FSH and LH. And if that is the case, you're not going to have menses. And even if you do, you're not going to have ovular menses. You know what that is all about? The eggs are not released. And if they're not released, there's nothing to fertilize. So, increased weight could be the only problem you have. Now, idiopathic, and luckily that's where I'll be ending. In medicine, when we say idiopathic, it means we don't even know the exact cause. It is either we've not done enough tests, enough physical examination, enough history has not been taken, or we've done all, yet no diagnosis. And if that is the case, there's nothing you can do, because some people are actually normal. Yeah, husband is okay, wife is okay, the pregnancy is not there. This is where a lot of things will set in. Not preaching sermon or anything, but then it depends on your faith. And with that, I've come to the end of infertility causes in both male and female. I will encourage the male partner to read or listen to this, and the female partner to go back to male infertility causes or causes of male infertility. Why? So that you can help each other. Kindly subscribe to my channel, and you can forward this to all your friends. Thanks for listening. See you again.